Good afternoon. Thank you for that introduction, Kelvin. It's a pleasure to be here talking about, as Kelvin mentioned, one of the most misunderstood but critical aspects of the U.S. healthcare system, which is reimbursement. And there's at least a few of you that look like you're here to learn more about reimbursement, which is great. I'll take it. So you're probably wondering, what's with the bridge here on the slide? Reimbursement really is that bridge between innovation and patient access. And this is a bridge, it's the Height Crossing Bridge in Lake Powell, Utah, about 400 miles south of where we are. It's the only crossing of the Colorado River for about a 300-mile stretch. So if you miss your turn, you're definitely in it for a detour or backtracking. And from my experience, reimbursement for new technology can feel like that sometimes. If you don't have a roadmap, if you don't have an early strategy, you may miss some opportunities. You may have some expensive delays. So today's session is all about what to start thinking about, the fundamentals of Reimbursement US and that roadmap and what it may look like for you. Okay, specifically the objectives today, we're going to kind of set the stage with the U.S. healthcare system. Who's paying, the mix of payers, private, public. We're going to get kind of technical with the three pillars of reimbursement: coding, coverage, and payment. And then Medicare is the single largest insurer in the U.S. So we're going to spend time looking at how Medicare determines coverage and the various payment models. Medicare is often the benchmark or the bellwether for other payers to set policy. And then sprinkled throughout, definitely some considerations for technology and innovation. We won't have time for Q&A. Sorry, but catch me. I'll be around this afternoon. I'm happy to try to answer any questions. We've got quite a bit of content here. So the U.S. healthcare system is massive. No other sector of our economy is this large or complex. In 2023, $5 trillion about was spent on healthcare, which is about 18% of GDP, a lot more than other developed nations spend. And if you look at where it's coming from, private health insurance contributes about 30%. Medicare, as I said, the single largest insurer, is right around 20%. Medicaid, 18%. And then you have some others: VA, military, Tricare. Okay. So it's massive. And I think the key takeaway here is reimbursement isn't just a billing process. It is actually how the U.S. manages and allocates 20% of the economy. And whenever you have this much spending, new technology is always going to be asked two questions. Do you improve outcomes, and do you save the system money? Okay. If you look at where the spending is going, about 31% is hospital care, and 20% physician services, outpatient, 10% prescription drug, and then a smaller share under durable medical equipment, about 1 to 2%, would be medical device. That's where I spend a lot of my time. And so what's important to note here is you're not going to be working with just one system. There are different stakeholders, different audiences, and different criteria when you're thinking about coding, coverage, and payment for innovation. Okay. So there are three pillars to reimbursement, and they're all interconnected. Miss even one of these, and your commercial success is a little less possible. Coding is the standardized language. This is how we convey to the payers what was performed and why, the patient's diagnosis. And it's how the payers know, okay, do I pay for this? Do I cover this? By looking at that coding system. Coverage is the question of whether or not they'll consider the technology medically necessary and under what conditions. And then payment, of course, is what the payers agree to reimburse for the service or product. And that's going to depend on what type of technology it is, where it is provided, what setting, what type of provider. We'll get into all three of these today, starting with coding. There are 4 main coding systems in the US. CPT codes, current procedural terminology. These are perhaps the most widely used in the outpatient settings, maintained by the American Medical Association. There's several opportunities per year to go to an AMA meeting and request a new CPT code or to request a revision to codes. We also have HCPCS codes, Healthcare Common Procedure System, maintained by CMS. And these are typically used to report supplies, medications, devices, implants, and these codes are used in the outpatient setting, outpatient hospital ASC. We have International Classification of Diseases Procedure Coding System. These are to report procedures in the inpatient setting only. This coding is pretty complex. It's like 7-digit codes, alphanumeric, every digit is like the body system and the device that's used, so that can be a pretty complicated system. And then the International Classification of Diseases Modifications, these are our diagnosis codes. These are used across all settings. It's the reason the patient is seeking care, the diagnosis, the condition, injury, what have you. So what's really important to note here is when you're bringing a new technology to the US, you have to know which coding system is going to apply. And what does that rule book look like? What's that timeline look like? Who's the owner of that you're going to be requesting a code with if you need a new one? All of that those are important questions to ask very early on. And I want to spend just a second on CPT codes, again, probably the most widely used. Not all CPT codes are created equal. Most technologies will start with a Category 3 code, and they'll move to a Category 1 code. Category 3 codes are supposed to be temporary. They're issued for 5 years, although they can be renewed. I've seen some hang out for a while. And they're pretty easy to get. You don't have to have FDA clearance. You should have at least one society that's supporting it. And they're typically for emerging technology or technology that may be considered experimental still. And they help. If we can get a Category 3 code, we can start tracking things. And so you'll often be a Category 3 until you can move into a Category 1, which is a much higher bar to obtain. Category 1 codes are permanent, and they do need FDA approval. Definitely need specialty society support. In fact, it's usually a specialty society or two that will actually put forward an application for a new Category 1 code, and they'll sponsor that. And then the level of evidence that you need to get a Cat 1 is a lot more rigorous. Okay? There's going to be certain evidence that you need. And then you need to meet widespread utilization. So you have to be able to show that you're performed by many physicians nationwide. Okay. And then there's unlisted codes. This is kind of like a short-term strategy while you're working on Category 3 or Category 1. They're non-specific codes or miscellaneous codes, we call them. So those are kind of what you're looking at with CPT codes. Okay, we're going to move to the next pillar, which is coverage. And I think what's important to note in the US is you have Medicare, which is the single largest insurer, but you are also working with a lot of private payers. 340 million lives in the US, about 66% have a private health insurance. They're covered by private health insurance either through their employer or direct purchase. About 35% are going to have a type of public plan that's going to include Medicaid, Medicare, Stryker, VA, and about 8% of the population is uninsured. And so while a lot of the payers will look to Medicare is kind of that benchmark, you'll be working with many different payers as you think about your market access strategy. A little bit more on Medicare. Total enrollment with Medicare is around 67 million individuals. Medicare accounts for about 20% of our healthcare spending. It's mostly for patients that are beneficiaries that are 65 and older, although there are some groups that are under 65 that are eligible. And the other payers look to Medicare. So if Medicare decides to cover something, very often other payers will follow suit. On the flip side, if Medicare questions coverage or decides not to cover something, you'll see the payers really take note of that. Okay, so Medicare can really be powerful. They generally cover things that they deem reasonable and necessary. There's 4 parts to Medicare. Medicare Part A is going to be inpatient coverage. That's going to include skilled nursing care, hospice care, home health care. And then Medicare beneficiaries can also elect Part B for outpatient coverage. So if you need to have an office visit or an outpatient surgery or durable medical equipment, that would be covered under Part B. And so patients that are on what we call traditional Medicare will have Part A and or Part B to go along with that. The other option is Medicare beneficiaries can select what we call Part C, Medicare Advantage. And these are plans that are managed by private insurers, and they're contracted with CMS to provide Medicare benefits. So a good number of Medicare beneficiaries are now on a Medicare Advantage type plan. And then Part D is prescription drug coverage. And that is also managed by private plans, although CMS does regulate that. Now, there are several options for pursuing Medicare coverage. There's coverage at the national level, national coverage determination process. This is a very formal, public process whereby CMS is going to review the evidence for a technology. They're going to review any practice guidelines, society guidelines, technology assessments, and they'll hold a meeting. They'll have a public comment period, so they solicit feedback from the public. And the whole process takes about 9 months from the time they initiate the national coverage to when they come out with a final decision. But it's 9 months from the time they initiate it. And Medicare has a pretty good backlog. So when thinking about pursuing maybe a national coverage determination, it could actually be 2-3 years with the backlog. Okay? But a national coverage determination is very powerful. If you get a favorable NCD, that opens the door to all Medicare patients, including Medicare Advantage. Nationwide, you'll have coverage with Medicare. On the flip side, if there is a negative coverage determination, that quickly closes the door to Medicare coverage. So it's a high effort, potentially high reward, or high risk. Okay, you got to ask yourself, is the technology ready to withstand national scrutiny? The other option is the local coverage determination process. So we have 7 Medicare administrative contractors nationwide across 12 jurisdictions, and they can come out with coverage policies on a regional level. It's a similar process. It's very transparent, public. They review the evidence. They come out with a proposed LCD. There's a comment period. And then if you get favorable coverage, it's going to apply to that region. And that's oftentimes how new technology will start. They'll work in a certain region. They'll maybe have a local champion. They'll get coverage. They'll start to continue, they'll build evidence and utilization. And then maybe they'll go approach the other MACs or start thinking about a national coverage determination. And then lastly, with Medicare coverage, you can also, without an NCD or an LCD, you still may have coverage. If your technology has a permanent CPT code, has established payment, you may still have Medicare coverage. On a case-by-case basis, you can submit claims. They may review records. That's often how we start with new technology in this space. With Medicare Advantage coverage, Medicare Advantage is interesting because it's the largest growing segment in insurance. And they are supposed to cover everything Medicare does, Medicare Part A and Part B, when there's a national coverage determination or local coverage determination. They don't have to pay the same amount, but they're supposed to have the same coverage. And as I said, it is the fastest growing insurance segment. More than half of all Medicare beneficiaries today have some type of Medicare Advantage plan. And it's also highly concentrated with just a couple insurers. United Healthcare, Humana account for about 50% of all enrollees. So the point here is, if your technology is used heavily in the Medicare population, and you don't have a national coverage determination or a local coverage determination, The Medicare Advantage plans can follow their commercial policies. So you might find yourself in an environment where, not only are you pursuing Medicare coverage, but now you're working with many different private insurers to lock in coverage. Okay, moving on to payments. And we're mostly going to focus on the Medicare payment structure. Commercial plans often will adopt Medicare structure, or they often have their own. But Medicare's payment structure is still very much set up on a fee-for-service model. So providers are reimbursed based on historical resource use versus value. And that's starting to shift, that's starting to change. There's some innovative models coming out, but for the most part, it rewards volume versus value. Good care is paid the same as great care. Now, some of these innovative models really, there's a little bit more risk put on the provider. If they participate and then they can show that they're improving outcomes or reducing costs, then they may get additional reimbursement. On the flip side, if they don't participate, they may get penalized and get less reimbursement. Okay, so these innovative models, we're going to see more of them in the years to come. I think AI will probably help, get them to be more widely used. They certainly are starting to shift incentives, but they haven't really changed the fundamentals of the fee-for-service payment structure. So there are multiple different payment systems that are fee-for-service. Again, these are based on resource use, historical resource use for the most part. They're updated annually in rulemaking. I'm just going to touch briefly on a few of them: hospital inpatient, hospital outpatient, ambulatory surgery center, and physician services. So in the inpatient setting is paid a fixed rate per discharge or stay. And every stay is classified into what we call a Medicare Severity Diagnosis Related Group, or DRG. And that can depend on the patient's diagnosis, the procedure. If the patient has any comorbidities or complications, that's assigned to a specific DRG with a weight. And that's multiplied by a base payment rate that Medicare publishes each year. That's how you get that fixed rate. So in short, it's very much a bundled payment for everything involved in that stay. Now, one thing that could have implications for new technology here is there is a pathway called New Technology Add-on Payment. And if you qualify, you can get additional reimbursement for a set amount of time above and beyond the DRG. So I won't go into details, but just know that is a pathway you would want to explore if you were eligible and not miss that opportunity. With outpatient, it's very similar, only there's a lump sum, there's one payment for the service or procedure. And all procedures are classified into what we call ambulatory payment classification, or APCs, and they have a weight. And they're put in APCs based on resources, clinical similarity, and then that's multiplied by a conversion factor that CMS publishes each year as part of rulemaking. And just like in the inpatient setting, the outpatient setting has an incremental payment for new technology as well, pass-through payment. So that's something to explore. If you're eligible, then you would get additional reimbursement above and beyond that APC reimbursement. Ambulatory surgery centers, there's definitely a push to move procedures to lower cost settings like outpatient hospital and ASC. ASCs are reimbursed similar to outpatient hospital, similar formula, but at a lower percentage. Typically, ASCs are reimbursed anywhere from 50 to maybe 80% of what outpatient hospitals are reimbursed. And then lastly, the physician fee schedule. So for every service with a permanent CPT code, there is this valuation process where specialty societies can recommend relative value units, RVUs. They make a recommendation, but CMS ultimately determines the RVUs. And there's three components. Work RVUs, that is the time, the effort, the skill, the stress to perform the procedure. Practice expense is the overhead, staff, those costs, and then malpractice is the cost of professional liability. So all three of those are added together and multiplied by a conversion factor, again set by CMS every year to maintain budget neutrality. and that determines the payment rate. Okay. So every year, you got to pay attention. We just had the physician final rule come out on Halloween. A lot going on there that impacts the physician fee schedule. You can't ever really stop paying attention. Even once you have an established payment, you got to pay attention to those rules, see what could be impacting you, submit comments during the comment period. So we've covered coding, coverage, and payment here. From my experience in bringing new technology to market, coverage is usually the hardest piece. You can do what you need to do with the FDA. You've been deemed safe and effective. You can legally market in the US. Maybe you have some Medicare coverage and Medicare's considering you reasonable and necessary, but that still doesn't mean the commercial plans have to cover the procedure. And we're working with a very diverse, large number of payers in the US. There are the major national plans, but then there are many, many regional plans. And so you end up having to really have, if you're going to have, if your technology is going to be in the private insurance space, you end up having to have a pretty aggressive market access strategy where you're working with individual payers, medical directors, policymakers. And they do care about, the FDA. They do care about any guidance that's come out from Medicare, any coverage policies. But when they're looking at the evidence, they also care about health economics data, total cost of care. They want to know that if they decide to cover something today, is it going to save them money down the road? Are there going to be fewer hospitalizations, fewer complications? So as part of your early clinical evidence development strategy, it's wise to be also thinking about health economics data and what the payers will want to see. They also look at practice guidelines. So part of the early strategy should be knowing who are your specialty societies that are applicable to your technology, and start to engage them early in the process, in your evidence development. And then don't underestimate a strong appeals prior authorization program. This might not come right away, but definitely as you approach commercialization. If payers aren't receiving requests and there's no demand from providers, they don't have any reason to reconsider their policies. But on the flip side, if they're getting a lot of requests and there's a lot of appeals activity and a lot of them are getting overturned and approved, that kind of wakes them up and they say, maybe we should reconsider our policy here. So that bottoms-up strategy can be just as powerful as the top-down strategy in terms of building your evidence and working with societies. Okay, for time's sake, I'm going to skip that one. Okay, I'm going to kind of bring things together here. Reimbursement really should be something you're thinking about very early in the process. When it comes to coding, you need to ask, is there a code that exists? And it can't just be a code that's pretty close. You got to have one that is specific to your technology or service. And if there isn't a code that exists, what pathway is going to apply to get that coding? What's that timeline look like? How is that going to impact your launch and your utilization? When it comes to coverage, you're asking, what clinical evidence am I going to need? Who are my stakeholders? Is it mostly going to be CMS? What evidence do they want? Is it mostly the commercial plans? What evidence do they want? More and more, payers want to see real-world evidence. Level 1 RCTs, those are great, but those are very controlled in certain settings with specific patient criteria. More and more payers want to see, what are your outcomes when it's actually real-world across the real population? And then payment. What payment mechanisms are going to apply? Are you going to be inpatient in a bundled payment? Is it a physician service and you're working with RVUs? Is it a device? And ultimately, is payment sufficient so that your customer wants to adopt the technology? And if not, are there any opportunities to improve that? We talked about some of those incremental new payments for technology. Okay. But the takeaway here is, again, plan early. Reimbursement really can make or break if your innovation is going to get to patients. Many companies will develop great products, great devices, and then reimbursement is kind of an afterthought, and that can be a costly mistake. It really should be integrated early into your clinical and regulatory planning. Okay. So with that, I'll show you another lovely picture. I love the Red Mountains. Just don't forget that reimbursement really is that critical bridge to getting patient access. Okay? And, here's my email, but also I'll be around this afternoon. If there are any questions, feel free to pull me aside. And thank you so much. Appreciate it.